Hi everyone, and welcome to the latest webinar from Zoe. Long COVID, what do we know so far? And I'm joined today by two eminent experts, Professor Emma Duncan, Professor of Clinical Endocrinology, and Dr. Claire Steeves, a reader in aging research, both my colleagues from King's College London and Guy's and St Thomas's Hospital Trust. I'm Professor Tim Spector, the lead scientist at the Zoe COVID study, and Professor of Epidemiology at King's as well. So thanks to everyone for submitting your questions, and we're looking forward to getting some answers to these and discussing this really important topic of long COVID. Now, with hospitalizations and deaths from COVID at really low levels relative to the number of cases, the next major thing we need to tackle is really long COVID, as this is going to be the main cause of long-term health issues. So in this webinar, I'm going to be talking about how do we define it, how do we get it, how do we avoid it, and how it can be treated, and what are the long-term implications. And we will have other more detailed webinars about subtopics after that. So the first topic is really what's it all about? What is long COVID? And its definition is actually quite controversial, and you see different figures all over the place. Okay, team, how do we define it? What's the best way to do that?
So I think, thanks, Tim. So one of the best definitions that's out there at the moment is by National Institute of Clinical Excellence, who had some good thinking about this back in about October, November last year, and produced the first sort of working definition. And it's very much under review, and it's a working guideline that they've produced. And so they basically decided that long COVID is more than 4 weeks of symptoms that are ongoing after testing positive for COVID, or indeed having an illness which is very like COVID, even if the test wasn't actually done. And the symptoms need to be going on for more than 4 weeks. And they made a second category, which was post-COVID syndrome, which is people who have ongoing symptoms for more than 12 weeks. And the important other part of the definition was that those symptoms weren't explained by an alternative diagnosis.
And do you think we're still going to be calling it long COVID in a year's time?
Well, I think ultimately, what in your introduction, Tim, you talked about long-term problems which might come as a consequence of COVID. And I think long COVID, as we've just described it, is one of the issues that we're going to be grappling with, which is when somebody has ongoing symptoms, often characterized by fatigue and difficulty then getting back to daily life. And that's probably what everybody understands as long COVID. But I want to remind everybody that there are really two main other sort of post-COVID sequelae, so sequences after COVID. One is that actually we see that people who have COVID are more likely to get a further diagnosis, like a new diagnosis of diabetes, like a stroke or a myocardial infarction, actually in the months after COVID. And of course, that might not be defined as long COVID, but it is still probably a consequence of the infection. And the second thing is that in people who are hospitalized, there's a post-hospitalization and post-ITU syndrome as well, which is a sort of a slightly separate issue from those individuals that have been very severely affected by the initial illness.
Yeah, so there's lots of different ways of defining it. It is quite confusing to the public, I think, and I think we are in this position, but I think we're getting closer to having better definitions, certainly. So,
Tim, could I come back to? Could I say something about what Claire just said in answer to your question about what we're going to be calling this in a year's time?
Sure.
Because I think one of the things that we're still, as a community, grappling with is this just one entity, or is there actually more than one thing which might be put into this conglomerate of called long COVID or post-COVID syndrome? And I think Claire alluded to that a little bit when she was talking about post-hospitalisation, that there are going to be some people who have long symptoms because they were terribly ill and were in hospital. And there are going to be some people who have long symptoms, perhaps because of autoimmunity. There may be some people who have long symptoms because they were frail initially, and that this has really hit their body even harder than it would somebody who was not frail. And I think over the course of the next 12 months, we're going to get much better at not saying one size fits all, but being able to think about this with more nuance. So I think that there might be this overall umbrella term, but I think we'll get much better at thinking about what in an individual person is the predominant contributor to their symptoms.
And do you think this is really the heart of what we need to do proper research in it? I mean,
Oh, definitely. And I think that, I mean, certainly I know that there are many groups who are working on this around the world. And it's one of the things when we've been putting together our own projects, we've thought about being able to think about people who've had short infection versus long infection, and people who've had confirmed infection, and those people who have not had confirmed infection, and as well as looking at people who've been very healthy throughout, because being able to look at all of the differences between these groups will help us to pass this. And I also think we're able to build from research outside just the COVID province as well. The stuff that's been done in the past about chronic fatigue, the past that's been done in the past about autoimmunity, the stuff which has been done in the past about anxiety and depression. All of this work will help inform how we plan research into long COVID.
And what do you think the main research, if you had to name 3 research questions that are the most crucial in long COVID, what would they be?
What is the cause? How do we fix it? And when does it get better? That's what I think most people would want to have as the top 3.
Okay, do you agree, Claire?
Yes, absolutely. I mean, I think the key thing is what treatments or what changes can I make that's going to help me get better quicker? That's the most important thing. And of course, getting to that means separating out the different versions and getting to the causes behind each version, because it's only then that we can then really start to be thinking about treatments. And
is that what you're doing now? Are you sort of measuring in that way, just sort of documenting everything?
Yeah, so that's right. We're documenting everything in terms of symptoms, but we're also, as Emma says, trying to understand a bit about the biology that might underpin some of the different presentations with long COVID. And so we're doing that ourselves, but also other groups are doing it. And we're really, as a long COVID research community, trying to come together and work really together and fast to try and get some of these answers as quick as possible.
Now, we've generally used 3 months as our criteria for our sort of internal research on how we're defining it. And that's used in a lot of other chronic disease definitions. Do we think that's the right figure? And what do we know how many people have it at 3 months but then don't have it at a year? I mean, what's your feeling of, because obviously we must be starting to get, you know, decent 1-year data now. What's your feeling of how many people get better in that time?
Yeah, so this is a very interesting question. And I think right from the very first paper we published on this, we saw that there was this sort of what we call a gamma distribution of duration of long COVID. And what that means is that the duration of symptoms is, most people are having quite short duration of symptoms. Then at 4 weeks, you get a proportion, probably sort of maybe between 10% and a quarter of people having symptoms for that long, and then at 12 weeks it's much less, but then there will be some people that are still having symptoms. We definitely know there are some people that have had symptoms since the very first wave back in April or March or April last year, but luckily they're very small numbers.
And I think we saw the same thing in children as well, Tim, that we were able to have a look at Littleys. And, you know, some children do get symptoms that last for over a month. But if one goes out to 2 months, those numbers really start to drop off. However, there are still some children who still have symptoms there. But I'd also...
Can you put a figure on that? What's the sort of
I can put a figure on that for you. So about 4.5% of children who have confirmed COVID have still got symptoms at 4 weeks. But by the time you get out to 8 weeks, that's about 1.5%. So it's really going down. But the other thing, which I think this is a good point for us to bring it up in the equation, this is not the first or the only illness that can have prolonged effects. I mean, when I was at university, it was glandular fever that was the big issue in terms of giving people long symptoms after they'd been ill. And in fact, the best man at our wedding got glandular fever and he was sick for a year. So this isn't the first illness, and it's not going to be the only illness that can cause long symptoms. And I think we can build on research done in other illnesses as well to help both understand this one and also think about treatment strategies, which we know have helped in other illnesses with similarities. They may or may not work, but it's a starting point.
Okay. Before we get on to some questions, just to remind people that, correct me if I'm wrong, but I think we're using this 3-month criteria, which is stricter than a lot of the other people are using, and it's 3 months where you can't perform your normal functions. So it's not just a trivial problem. It's actually interfering with your life. We get about 1.2% of like 20-year-olds and about 4 to 5% of middle-aged and older. Is that roughly right, Claire?
Yeah, so together with lots of other groups that are working on the longitudinal population studies across the UK, we've been able to cross-compare in lots of different settings now, and we see that the rates do change with age, but as you say, the rates of debilitating long symptoms for more than 12 weeks range from about 1 to 2% in the 20s to about 5% in the sort of 60s year age groups.
Yeah, and I guess we'll probably have to leave that for another time, but it's a question of whether the risk in long COVID in kids is going to be greater than the risk of side effects of the vaccine, and that's a real point of interest. That's why this data is so really crucial to try and unpick, aren't they? Yeah. Okay, let's get on to some questions. And these are people who've been asking how they can tell their GP about having long COVID. And this is from Anonymous. Is anything going to happen to allow patients to be believed by their GP? Someone's really frustrated that mine doesn't believe that I've been suffering since last March. So, is there going to be help for people like that to sort of back up that problem where the GP may not have seen at the beginning, and they don't really know the history, and there's no tests as far as we know that are any good on this. So how do you think this is going to be solved in the future? I mean, we can't change the past, but how's it going to work? And Emma, any ideas?
Well, the first thing I was going to say is that one of the things is obviously that the disease is recognised, and the World Health Organization has recognised it as an entity. So the first thing is it recognised by medical authorities? And the answer is absolutely yes. And Claire also mentioned NICE, the National Institute for Clinical Excellence. Again, it is recognised as a condition. So that's the first thing. Is it fictional? No, it's recognised. So the second thing is, how can you tell? And I think the issue about having been sick since last March and not being understood, I think one of the problems is that testing wasn't widely available last March. And so I think it does put GPs in a difficult situation, that if they've got somebody who's complaining of symptoms but there was never any proof because this person was never tested, I actually think that makes things hard for GPs. And I think going forwards, the fact that testing has been more widely available since September will make it much easier for general practitioners, and that this is a formally recognised entity. I know there've been a number of guidelines to general practice as well, and perhaps Claire, you might talk to some of those.
Yeah. So thanks, Emma, because actually the NICE guidelines are jointly produced by the Royal College of General Practitioners, and the Royal College of General Practitioners have been really active in the development of that guideline. And very specifically, they were very keen right from the start that you do not have to have a positive test in order to have long COVID. You could have an illness which is consistent with having had COVID. So around the same time, if you were ill, then that gives you don't have to have had a positive test. But I would say that the Royal College of General Practitioners are really trying very hard to educate GPs. This is a whole new disease, a whole new area. Many GPs need to know about it. They've introduced SNOMED codes. These are the codes that the GP puts into their computer system in the practice to try and help GPs recognise this. And they're really trying to work with GPs to make sure that happens so that people get the right diagnosis. I would say that hopefully this is going to be much less of a problem as GPs come to recognise it more. We've certainly seen that the use of those SNOMED codes is improving, although we still know that the number of people being identified is much, much less than what should be being identified. And that may be partly GPs not recognising, but also partly people not going to see their GPs if they have long COVID symptoms.
Okay, just to wrap this up, and there are lots of questions on this. Catriona is another one who's not being believed. And some people saying, oh, well, this happens in all viruses, there's not much you can do about it, nothing different about this. What do you advise people whose GP doesn't believe them? Do can we give them any advice, or just say try again, because they will be getting more information?
Yeah, I think that's absolutely right. I mean, I've been involved in some of the training initiatives for GPs, and that they will be getting more. I think they should sort of say to the GP, I think I've got this, what do you think? But of course, remember as well, one of the key things the GP wants to do is make sure it's not something else. And I think that's a real reason to actually go and see your GP to get various tests done. Because, for example, if you're anemic, you can have symptoms that are very similar to some of long COVID symptoms. And there's always a cause for anemia. It needs to be investigated. Likewise, weight loss, loss of appetite, all these things may have other causes. And people do need to have those things addressed. And so I think there was another person, Tim, who was asking about all my investigations are negative. Does that mean there's nothing wrong? Of course not. Those investigations, the purpose of them is not actually to diagnose long COVID, because at the moment we don't have a test for long COVID. What those investigations are for is to make sure there's not something else that actually we do know how to treat that's causing you to have symptoms that could be muddled up with long COVID. And that's really important that people understand.
Okay, and a final word is just, there will be some people who do have rather unusual symptoms that are very specific to COVID that GPs might not know about. Things like these very specific COVID rashes and COVID toes. And I think these are, and of course, loss of smell and taste if it persists. It doesn't really occur with other common virus conditions. So there are a number of things that might be able to help some people convince their reluctant GPs. Okay, so keep trying is the answer to everyone there, and get the message out. Get your GP to listen to this podcast. Okay, now moving on to the next topic, which is really about the results of the study. And I'm going to start with, we've discussed how many people are affected, so between 1% and 5%, depending on the age. But Claire, someone's asking who's really affected by it, and what are the risks in people who've been vaccinated? Because I think most of the people listening to this will have already had a vaccination, and so that's on top of their minds at the moment.
Some good news here.
Yeah. So going back to sort of who's most affected by COVID, what people are most at risk. We do see there's an age gradient, and that's something that's seen across all studies actually, that you're more likely if you're in your 60s or 70s and you get COVID to get long COVID. But of course, there's been a lot of interest and anxiety and caution as well about younger people. And this is because obviously 3 months of being debilitated for a young person who's doing exams or going for their first job interview, these are really important parts of life where people are certainly not expecting to be debilitated. So even though the risk is lower for individuals who are younger, the risk may have very significant impact upon their life. And so that's one reason to really care about the risk of long COVID. Now we've got a very large sort of number of people affected, and particularly people who are young and not vaccinated. And that's where we come on to the really good news. We can see, and we've pre-printed already, our early data on this, which showed that we saw a reduction. So first of all, your risk of getting COVID is much reduced by having a vaccination. I mean, a single vaccination, it's at least 60% reduced. A double vaccination, it's at least 85% reduced in all of this sort of analysis. So that's a big reduction, definitely. And that's been known about for a while. But what we see that actually, if you are unlucky enough to get COVID after having had a double vaccination, your risk of long COVID is dramatically reduced, and it's dramatically reduced in all age groups. I think that's a really, really important message to get out there at the moment, because young people can sort of, get rid of that risk of having a big functional sort of impact upon their lives if they get vaccinated.
So,
and I would just
just put some figures on that. So you're saying roughly a 6-fold reduction in getting COVID in most, if you've been double vaccinated, and then a further bonus of what on top of that,
at least another half.
Neither other half of that. So okay, so it's suddenly going to less than a 10-fold reduction really in your risk, roughly, depending on your age and everything else. Okay, that's really helpful.
It's great news, and I just wanted to build on what Claire also said about if you are unlucky enough to get sick to catch COVID after you've been vaccinated, your symptoms and your chance of going to hospital are that much less. And what we found in our earlier paper also wasn't just that the older people the more likely they were to have prolonged duration of illness. The sicker they were early on in their infection also predicted their chance of having prolonged duration. So this benefit in having, it's not just that you're less likely to get COVID substantially. It's not just that if you do happen to contract COVID after vaccination, you're much less likely to have long duration. You're also much less likely to get really sick or have to go to hospital. So these are all great benefits of vaccination for long COVID as well as for acute COVID.
Great. Okay. So let's, anyone else who's within that group, any other predictors of who's more likely to get it apart from age?
Yeah, thanks for bringing that back, Tim, because I did want to say, so we looked at various different things actually. So demographic factors, women are more likely, possibly twice as likely to get long COVID symptoms than men. And that's interesting. We don't know exactly why that's the case, but Emma, I'm sure you could come in here on differences in autoimmune disease between men and women. We see that, and maybe that is sort of like signals that immune system might be to play. But there's another thing that signals immune system, and that is asthma. People with asthma before they got COVID, we've seen in both our study within Zoe, that was published in Nature Medicine, we were the first to show that asthma increases the risk of long symptoms. But now that's been replicated across 12 UK studies, and that's asthma diagnosis beforehand. And it may be that people with asthma have a slightly different form of long COVID. And anybody with asthma, who's listening might be aware that if you get a nasty cold or another flu, it tickles your lungs for quite a number of weeks or months afterwards. And indeed, people over this whole time who have asthma, who have not been infected by COVID and also not been infected by other things, some people have reported improvements in their asthma. So that's interesting. But apart from asthma, Tim, previous general health was important, and previous mental health. So people with more anxiety and depression were more likely to go on to get long COVID, but the risk ratios were not very high. And of course, there's many more people who have completely normal background health that go on to get long COVID than people who have problems to begin with.
And coming back to I'm bringing Emma here on the female-male question. So if females are more likely to get it, obviously they have slightly different immune systems, but we probably haven't got time to go into that. But a lot of women take HRT, which does that make them, more female than male, and therefore more at risk of long COVID, or do we know anything about, or does it help? I'm
going to give you a very generic answer here, Tim, and I'll say that what HRT definitely helps with is symptoms that are related to estrogen deficiency and other hormones in menopause. I think commenting beyond that in terms of symptoms with long COVID at the moment would be premature. So, I think Claire's comment about anemia is a really good example about how symptoms can overlap from different conditions, and thinking through and with your GP, is this just due to COVID or is this due to something else, is an important research question for us to think about as well. With this comment about women, and particularly older women, is there an overlap in symptoms here that needs to be thought through and perhaps, perhaps it is that for some of these people, it is something else that needs addressing rather than long COVID per se. So all I'm going to say about that is that HRT is extremely effective at helping to deal with symptoms that are related to menopause. And I'm not going to comment further with respect to long COVID at this point in the story.
Okay, we'll leave it there. Thank you. Very diplomatic answer. So the next question is all about ME, actually, which is another controversial topic. And Sarah says, I've had long COVID for 1.5 years. Seems exactly the same as ME, chronic fatigue syndrome. Our research is going to work with the ME researchers in this area, and maybe Emma, you can.
I was just going to say absolutely, and we've been working with some of the NIHR projects we've been putting together at working with people who have a lot of experience at working with chronic fatigue, at how to manage it, how to get, what are useful strategies to help with it, acceptance therapies, exercise therapies for some individuals, dealing with the difference between physiological breathlessness versus psychological breathlessness. All of these types of programs which have been developed for chronic fatigue will certainly be considered. But I would come back to say,
the question actually asks, what are the similarities between them? What do we know? Before we get.
Well, I'm actually going to answer the question, but a slightly different one, which is to say, what is a key difference? And I think the key difference is what Claire was emphasising earlier on, which was that people have either had COVID or have had a COVID-like illness, to say early on. So I think that's an important distinction between them, that here we have got a slightly different framing in terms of the series of events that has led up to an individual having these particular symptoms at this point in time. I'm actually, with respect to symptoms and similarities and so forth, actually I'm going to reflect that one back to you, Claire. Or in fact,
symptoms. No. So I think it's a very, very good point, isn't it? That fatigue is a very sort of prominent symptom of long COVID in every investigation that's been done of it so far. And so I think that there's definitely a lot that can be learned from methods that are helpful in chronic fatigue syndrome and ME that need to be put to play in the management of long COVID. And the good news on this, that the National Institute for Health Research in the UK has just announced, literally I think on the weekend, about £19.5 million that's been put for really translational research into this. And you'll be very pleased to hear that most of the projects that are being put forward are really very much together with individuals that have experience in managing fatigue and pacing and so on.
And breathlessness and wear exercise. Can I come back to what Claire was just saying there? Because I think this comes back to talking about what we did earlier, that we're going to need to think about a personalised approach here, that one size is not going to fit all, and helping to understand the causes may also help us to work out what would be the best solution for you. If your predominant issue is A, then a management program focusing on A might be the best for you, rather than a management program focusing on D, E or F, which might be appropriate for somebody whose predominant issues are D, E and F. So I think we're going to see refinement and personalising of programs of management building on the experience of the chronic fatigue community.
But well, the next topic we're coming to is really what's next for long COVID, and we'll be asking, well, how can we treat it? And before we get on to the specific question, why don't we have any trials of steroids yet, or are there? I used to be a rheumatologist, and steroids cure all kinds of immune problems, and they help people with asthma and all kinds of stuff.
They certainly do, Tim, but they come with a lot of side effects, and so steroids are fantastic.
Wouldn't it be? I know you're not pro steroids, but
no, I'm extremely pro steroids in appropriate circumstances.
Short burst of it.
So
do you think we should be having trials?
So that's an interestingly way to phrase the question. It's a very Guardian headline way of phrasing the question, if I may, Tim. So I think the answer to the first thing I'd say is there's no doubt that in extremely ill individuals in hospital, the simplicity of dexamethasone has made a massive difference to outcomes. So there's absolutely no doubt that in serious acute respiratory illness, steroids make a big difference. I think the evidence in rheumatology, where you've got a clear inflammatory illness and that steroids damping down inflammation, is phenomenal. I'm sure there are some people here who are listening who might remember before steroids were used for rheumatoid arthritis. I think that was first back in the 50s. And as an endocrinologist, people's lives were saved once steroids came into use for Addison's disease. And people may or may not know this, but John F. Kennedy had that particular tan not just because he spent a lot of time on the beach, but actually because he had Addison's disease. So his life was saved by being able to give him steroids. There are people listening, no doubt, who have asthma, who without inhaled steroids, they would not be able to manage. So I am definitely a fan of steroids in certain circumstances.
Claire, can I bring you in here, Claire? Are you aware of any trials going on?
No, yeah, I am. Yeah, so people will be aware about the recovery trial, which and the recovery trial group was for use in hospital settings for treatment of acute COVID. But there is the same group of experts and individuals that are sieving through and looking at all the different options of treatment that relate to long COVID and also post-hospital recovery. And for example, one thing that I have spoken to the PI about is the HEAL study, which is for post-hospitalisation. What's the best management there? And they're at the moment trialling 3 different groups. Then it doesn't happen to be ongoing steroids, but it is blood thinners. It is things that help with metabolic management, and it is other medications like statins that they're looking at. There are the same sort of group is also helping out these other studies that I've alluded to that have just been recently funded, and I haven't heard exactly what the interventions they're going to be, but they'll probably not just be medications. They'll be principally also therapy and rehabilitation and a graded program of these, because some people can maybe do it online and some people actually need to be seeing doctors and physios and so on face to face.
In person. And I want to come back, Tim, to something Claire said earlier on. She said there is no test at the moment for long COVID. And I think that's a very important point in considering a medication like steroids, which are particularly good for inflammation. At the moment, the evidence that there is prolonged inflammation as the cause of long COVID for most individuals, at the moment, that is not clear at all. So although in certain circumstances, I'm a big fan of steroids, steroids also can cause a lot of side effects. And so it's always a balance between side effects on the one hand and benefits on the other. So I would not be a fan of splashing it about without due consideration.
Okay, made that clear. What about exercise? This is quite controversial because there have been some trials in chronic fatigue syndrome, ME, that haven't gone well with exercise, and there are definitely trials ongoing in this. Do we see this as, again, trying to work out that some people do well on it, other people do bad on it, and how do we, we're not used to this in medicine, this very individualized approach. So how do we get through this, do you think?
I think you're absolutely right, Tim, that again, a one-size-fits-all is something that we need to rethink about how we approach management of this. So I certainly know that there are people who are working who have experience and background with respect to exercise, physiotherapy, and targeting it. And for some people that will be very effective, and for other people it will be not so effective. So I'm going to give you a hand-wavy answer on that one.
Well, so actually this is actually a specific sort of focus of some of the grants that have just been funded, in that actually I think we do know that it's really important to pace any kind of great, exercise or even just physical activity in this context. And the reason why is because many people report, both who have long COVID and who've had other similar illnesses, that there's this sort of boom and bust. Do too much and you'll be sick for, you'll be out of action for several days. And we can try and sort of like not have that process going on if we take a really very paced approach. And there are some online sort of tools and resources that people are putting together to try and help that, and to actually then trial those and see whether they make a difference in helping people pace and individualize what they do, so that it meets that real need. Yeah.
Okay. Now here's something that we're all interested in is diet and COVID, and we've published several papers on diet, at least in preprint, which has looked generally and said that yes, quality of diet is really important in preventing severe problems of COVID. Can you just remind us, Claire, whether there was any suggestion in the data that as well as good quality diet, which was probably microbiome friendly type diets, there was any evidence that it helped reduce the duration of long COVID?
So Tim, we haven't been able to see that signal, to be honest, but that's partly because, of course, the diet data that we always have is only to a certain extent complete. It's self-reported data, and I think if there was a way of measuring diet even more accurately, Tim, or maybe using biomarkers of diet, for example, the microbiome, we might be able to find signals that are there that we can't find with our existing data. But we do see, as you have said, there is a relationship between severity of symptoms and the diet that someone held before they even got COVID. And we've also seen a signal which is there for infection post-vaccination, that individuals that have a healthier diet appear to have less symptoms post-vaccine if they get infected post-vaccination.
So although we haven't proven it, it's quite likely, given all those things you've said, that it does impact long COVID. So a reason for everyone to look at their diet. And another question was, well, if so, what should we be eating? And I guess that's probably whole other webinar on that, but eat for your gut microbiome and you can't go wrong. Lots of plants, fermented foods, and cut out the junk food. Now, we need to move on. So I think we've covered this next question mainly, which is what are the long-term implications of long COVID? So I think, do you want to come in just quickly summarize that, if you could, Emma?
Well, I think that Claire put it very nicely to say that the long-term implications are how it affects your life, symptoms, and how it affects your ability to live your life is the long-term implications. But I wanted to just say, to emphasize that the biggest evidence we have for something that makes a difference to long COVID at this point in time is vaccination. Because at the moment, both in terms of your chances of getting infection, if you don't get infection, it's hard to, if you don't get infection, that's a great start. But even if you are unlucky enough to get infection, your chances of getting long COVID go down. So I think that the evidence we have at the moment, the clearest thing that we have that will help prevent long COVID is vaccination.
Okay. So
would you agree with that, Claire?
I think no one's going to disagree with that. I think, all right, so another question here is people are worried about our healthcare system being overwhelmed in the aftermath of, the acute infections. We're getting long COVID rates estimated around 700 a day. We're creating now from the Zoe estimates, and these are adding on to, the large numbers, hundreds of thousands that are already there before. So, can our NHS cope with this? Do you think there's ways of dealing with this? Because even slight increase in admissions is going to affect capacity. We're already got 5 million people waiting to start treatments. The NHS is in a really, really bad place. So, any thoughts on how we're going to, any good answers for the health secretary to deal with all these multiple problems? Who wants to start with that one?
Well, I'm going to start by saying that this isn't something that has to start tomorrow, because actually it's been going on for some time now, that people have developed long COVID clinics. Certainly in our own trust, there are long COVID clinics for adults and there's long COVID clinics for children. So these planning for this and putting into place structural support for this has been going on for a while. I'm not saying that there can't be more done, but I think that it's also important to remember that these are the only illnesses that are in the community. Many people in the community have put their cancer treatment, their ischemic heart disease treatment, their diabetes treatment, all of their pituitary disease, their osteoporosis treatment. Everybody else in the community has been, who has not been able to go to hospital, has not been able to attend their routine follow-up over the last 15 months or so. These people too need to have, we have a backlog of other chronic and serious illness that will need looking after, with a workforce who've worked extremely hard over the last 15 months. So I think that there's the implications from long COVID, but there's also the implications of an inability to deliver chronic care for chronic conditions over the last 15 months. And that's going to have to be remembered. And in our study with kids, one of the things that we demonstrated was that there were children who had long duration of symptoms that were not due to COVID. And although there weren't very many of these kids, actually their burden of disease at 4 weeks was greater than the burden of disease in the children who actually were proven to have COVID-19. So it's important that we don't
get lessons there.
Other illnesses need to be looked after as well.
Okay. Claire, any final word on this?
So I think the one sort of ray of hope is that actually there has been quite a lot of development of how we can use new ways of working to be much more efficient. And I think that telemedicine, so the ability to sort of interact with patients across a phone line or across a video call, to know how to do that, how to do that effectively so that it's got good access for patients. Actually, it can be much more efficient for both patients and the healthcare staff, and might be one of the ways to really get the backlog out, that we make sure that we use all the facilities we have to make the interaction we have much more efficient, so that people don't miss out on their follow-up and their long-term condition management, but they perhaps do it remotely where less time is utilised.
Yeah, that's a really good point. It's a really good point, Claire. So I think, and I think everyone on the Zoe app and has shown how easy it is to use an app to exchange health information, and how you can cut out the GP and actually get all of this information done, and particularly on chronic diseases. And so I think all these concerns have forced us to rethink and say, well, how can we use our app to bring in a wider healthcare reporting for illnesses like dementia, heart disease, bone and joint problems, because we've been focusing on COVID the last 18 months, and this has left all these other illnesses neglected. So I think it's really important, and I think you'll hear more of us on this topic soon. But we need to wrap up. We're going to have some more webinars on these other topics in the future. I want to really thank Claire and Emma for giving their time, joining us today. Thanks to everyone who joined us. Fantastic questions, and of course, we love you loggers. Just a reminder, the Zoe COVID study is an essential tool used by government to help track the pandemic. Keep logging in the app and sharing with friends and family. And we'll be sharing any useful links here, and keep an eye out for those. Do subscribe to Zoe so you get these videos as they come up in the updates. And lastly, thank you. Stay safe and keep logging.